Welcome to The Local Lens. I'm Jenny Pastusak, and joining me today is Dr. Robert Joyner, the director of the TidalHealth Richard A. Henson Research Institute. Thanks for joining us, Robert.
Thanks for having me.
So let's talk about who you are first, and then we'll dive into what it is you do. So tell me a little bit about your background and how long you've been with TidalHealth.
Okay. So I am a Salisbury University graduate. I think I should say that. I have a bachelor's degree in respiratory therapy. Salisbury University is the only university to have a baccalaureate degree in respiratory care in the state of Maryland, so good reason to come here. I traveled as a respiratory therapist for a while after I graduated from here. I worked at Tulane in New Orleans, I worked in Boston, I worked in New Hampshire, and I worked in Maryland. And I decided to go back and get a doctorate. I have a doctorate in physiology from Dartmouth Medical School. I studied pulmonary hypertension at the time, so that's what that is. I came back to Salisbury in 1998 to work as a faculty member at Salisbury University and have been around ever since. And in 2019, I joined TidalHealth to be the director of research at TidalHealth.
Let's talk about what the director of research at TidalHealth does, because I mean, people's minds could be going in a million different directions. What are you researching?
So research should be thought of as a very broad term that goes from surveys that we provide patients to medical interventions that we provide patients. And TidalHealth is not a place that's going to find a cure for something like cystic fibrosis.
Okay.
But it is a place where we want to be able to offer state-of-the-art medicine. And research at TidalHealth is all about finding ways to offer state-of-the-art medicine to our community and have it so that that community, the members in our community, don't have to travel hundreds of miles to gain access to that care. And so there is an understanding of what standard of care can provide. And research is an extension to that. So the question is quality of life, things that are related to the best medical care that you can receive. We know what that standard of care can offer. Can we do more?
And okay, what about, the first thing that comes to my mind is that do you collaborate? Let's say you do research and you find something that's going to assist in serving the community. Are you sharing that with, you don't want our people to have to travel, but what about others? Do you share that knowledge?
So we do.
Okay.
In a number of different ways. So we have a collaboration with the Johns Hopkins Clinical Research Network. So we bring research from Johns Hopkins to the Eastern Shore, so you don't have to travel all the way to Baltimore to get that care. But we also publish in literature in regards to what our findings are. And so that's important because it gives people the opportunity to really think about what they're doing in regards to research and then participating in getting that information out to the world. So not only are we supporting state-of-the-art medicine that's here on the Eastern Shore, we're sending that information out so that other people can use it also.
Right.
Yeah.
And I think that that's important because, not everyone has access to the same types of health care.
No. So those disparities are part of what we're actually studying.
Okay.
So sometimes now they're referred to as social drivers of health or social determinants of health. And one of the questions that TidalHealth is trying to answer is what's the best way to offer health care on the Eastern Shore? It isn't just heart disease or cancer or other sort of disease processes that come to mind when we think about research. It's things about how do the mechanics of medicine work and what's the best way to gain access to individuals or provide access to individuals who may not have access or may not think they have access. So it's not the access itself, it's sort of what is the process that we need to develop so the access is better. That's what research is.
So why is it important for TidalHealth to invest in clinical research?
So TidalHealth is the largest healthcare provider on the Delmarva Peninsula. Its reach is wide and long. It goes from the Eastern Shore of Virginia to southern Delaware to west to Cambridge and all the way to Ocean City. So we are the ones that are supposed to be doing this, right? If we don't do this, nobody else is going to. TidalHealth has taken on that responsibility, and they're supporting a research institute for our community. And that's what we're doing in the Research Institute.
Let's talk about the trials, because
Okay.
that, to me, from an outsider's perspective, if someone were to come to me or someone I cared about and said, "We're gonna, would you like to go on a clinical trial?" That's scary. That doesn't mean it's you're testing it like a guinea pig, like we talked about, and that scares a lot of people. Can we talk about what that really means, clinical trials?
So research has phases associated with it, and commonly when people are thinking about the word guinea pig, or sort of being concerned about, do they know what's going to happen to me when they give me this drug, that sort of thing, right?
Yes.
TidalHealth is not a place that does what's referred to as either first in human or phase 1 trials, which commonly are called safety trials. And what they're really sort of looking for is to make sure that any sort of drug is safe and not necessarily the efficacy of it.
Okay.
We're involved in phase 3 trials and above. Phase 3 is actually where they understand the efficacy they understand the safety of the drug, and they understand the efficacy to the point that they need more data. And so the question really is not about whether or not this is going to work this time. It's more about gathering more data so that they can understand how well it works, and what the implications of that are so that the drug can be used in a way that is the best for the way in which that drug should work, right? How should it be administered to people? The other thing that we do is called phase 4 trials, or trials that are related to gathering information after drugs are made available. So one of the things that I think people don't commonly understand is that there's data collection after the drug's made available, just to keep assuring that they're monitored in a way to make sure they're safe.
That's important.
It is important. The other thing that's important is that when you participate in a trial, you're really sort of receiving that state-of-the-art medicine. It's the thing that we're doing the best that we can do with. And so that provides an opportunity for us to interact with patients, though not necessarily the way that general healthcare interacts. So for example, if you're on a clinical trial, you have access to research nurses all of the time, you have access to the Research Institute. So generally there's a layer of connection and safety that potentially isn't there on a daily basis for when you just go see your general care practitioner. I'm not saying that's wrong, I'm just saying that there's more to it when you participate in a clinical trial.
When you have access means I can call the doctor or the nurse and ask any question I have.
Any question you have. I have a new ache and pain, and I'd like to know if that's related to the clinical trial.
Okay.
And you don't have to wait 6 weeks for your next meeting. You can actually make phone calls. You can talk by email. There's lots of ways that you can connect with my staff.
I mean, that's such a valuable piece of the equation, because you're going to have questions.
It is the most common thing that's told to me, to the patients that are in our trials, is that my team, which I'm very proud of, is the reason that they participate in these clinical trials, is because they believe they get better care because of it. And actually, I believe that's true also.
Let's talk about your team. How big is your team?
So I have 15 employees.
Okay.
Some of them are research nurses. Some of them are coordinators. I have an administrative assistant. I have a manager of research operations. And all of these people work together to be able to provide these clinical trials on the Eastern Shore. So you can envision that maintaining safety and something called regulatory requirements by the federal government are complex, right? Yeah. And to be quite honest, for some people, that's the reason that they worry about getting into a clinical trial, is because of all of the requirements that are there. But those requirements are built for safety, and TidalHealth, we carry out those requirements for our investigators and for the subjects that are part of our clinical trials. That full-time people the 15 full-time people that we have are the ones that are supporting the clinical trials and making sure that they're going off without a hitch.
I guess it's like, am I just taking the medicine and you're checking in with me and you're just recording all of my experiences? And
so it could be that you have scheduled visits, and when research is taken on, when it's performed in what I'll refer to as a systematic way, because we have to understand whether things that you either experience or don't even recognize that you're experiencing are related to the clinical trial or sort of just part of daily life, right? Trying to know the difference of that. And the only way that you can really know the difference of that is if you have a group of people who are going through a clinical trial, they're receiving a particular pharmaceutical, and people who are going through a clinical trial and they're not receiving it, they're receiving standard of care. And you can compare those two things and you can see if there's a difference. And that way you can know whether or not any improvements or otherwise are related to the intervention as opposed to just daily life.
The word placebo came to mind.
There is a design for research which is considered the standard practice of research called a randomized control design. So we would have to talk a bit about what bias means. And bias is this idea of, a researcher is probably going to believe in what they're doing, right? They're going to believe that that's going to actually work out. That's called bias, okay?
And they can't really control that.
They can't control it. We can't control it.
It's just
right?
human,
it's human. And we want our stuff to work.
Sure.
Right? So what you have to do is you have to present this in a way that's blinded to the researcher, blinded to the individuals who are receiving it. Some people might receive a particular investigational product, and other people might receive standard of care. And that way, if it's randomized, blinded, you can have an understanding that the effect that you're seeing is real and not created by bias.
Understood.
Because the other thing is placebo effects are real. If I convince you that you're going to get better, some people do, at least to some extent.
You are the placebo effect.
Yes. And we have to know whether or not the science is actually working, right? And so the best way to do that is to blind everybody.
Okay.
Yeah.
That's understandable and fair,
Yeah.
fair to the study and, the people going through it too.
Yeah. So placebos are complicated in that placebos are generally thought to be sort of no care, right? So the idea of either you're going to get something or you're going to get nothing. And not all clinical trials are designed that way. It could be a comparison of drugs, right? It could be a comparison of this drug versus that drug, or a comparison of a new drug and standard of care to see whether or not that new drug actually has the effect that we're looking for in the patient population that's here. One of the attractivenesses of research here is because we have such a unique population here. If you think about the people that are living on the eastern shore of Virginia all the way to southern Delaware, we have a very wide reach in regards to what our population is. But we also live on a peninsula, and that peninsula captures that population for research, and so we're a very desirable group.
You said peninsula, and it made me think environmental could be, it's the people are all different, but our environment here, where we live, is different too.
Agreed.
And that has an effect.
It does. That conversation... That conversation usually goes toward cancer, right? The Delmarva Peninsula, unfortunately, does have a high rate of cancer. And the question usually goes to people who believe pretty quickly in regards to it's chicken farming, it's the water, it's whatever those sort of, it's eating crabs,
the
right?
Rural area,
there's all kinds of things
sandy,
I've heard.
Yeah.
And I will tell you that if the answer to that was that easy, if we knew that it was because we ate crabs, if we knew that it was because of poultry farming, we would know that. There are lots of people who are studying this. It's not that simple.
Right.
So I think that's important for people to know. One, that people are looking into this, and two, it's not as simple as saying it's because we eat crabs.
Can we go down the diabetes path too? Because the rate of diabetes here on the Eastern Shore is, what, more than double the national rate?
Sure.
Why?
So probably because we eat a lot of fried food. Now that one probably we can figure out. And all of us work really hard, and not all of us exercise every day, and
Fair.
there's pretty typical ways to get to diabetes, unfortunately. My hope as a researcher is some of the new drugs that are coming on the market, I would love to participate in bringing those to the Eastern Shore sooner than they're coming about, so that our community can have access to those new drugs that are supporting diabetes and other diseases that we have here.
But I can say that lifestyle does make an impact on
Lifestyle makes an impact.
Okay.
It sure does.
Thank
It makes
you
an
for
impact on everything.
Sure.
So even with the cancer discussion, I'm not suggesting that, we live in Tobacco Row, and I don't know if you know what I mean by that, but going from the eastern shore of Maryland down through the eastern shore of Virginia all the way down to North Carolina, right? I don't know where you grew up, but I grew up in Calvert County, and I can remember huge fields of tobacco, and everyone smoked, right? We know that smoking causes lung cancer. We know that, and we have a lot of lung cancer on the Eastern Shore, and it is because we live on Tobacco Row.
Tobacco Row. I'm from PA.
Okay.
So I don't know if that's in the trajectory of...
So I'm probably quite a bit older than you. However, I remember my mother going to barns and stripping tobacco to make money. And you just don't see that anymore, right?
No.
The fields that are here now are filled with corn or soybean or other watermelon, other sort of products. But I don't remember the last time I saw a tobacco field. And when I was a kid, they were everywhere.
That's interesting.
So, yeah.
Okay. So like we said, what lifestyle makes a difference.
It does.
And if anyone watching can take that with them, then, that, not that you can control everything, but that's one thing you can control.
No, life is, researchers are very comfortable with the idea that we don't know everything.
Okay.
And I don't mean that in a way other than just to say we're okay with the gray, right? That we fully recognize that we don't know everything, and we like to ask questions. That's where our enthusiasm comes from. And so life is inherently risky. Everything that we do carries a risk with it. And so, I'm a respiratory therapist by trade. Quite commonly, somebody will say not everybody gets COPD when they smoke. That is true.
Okay.
It is true, but you can certainly reduce your risk if you don't smoke.
There you go.
Does everybody who eats fried food have a heart attack? No, not everyone does. However, your risk is higher if you do. So understanding that and reducing your risks wherever you can doesn't make it so something won't happen, but it sure does improve the idea that it may not.
Absolutely.
Yeah.
The other word that comes to mind is assumption. You, as a researcher, there's no assumption. It is the data, correct?
Correct. One of the things that my team hears from me all of the time is that I don't do I think. Because I can't. I don't have that in me anymore. So when somebody says, I think this is the reason why, right? Then for me, it's you don't know. And I'm not going to stand on that hill until I have a better understanding of what that is, whatever that might be. A good example of the way that I work. So if I'm going to go and do a presentation somewhere and I ask somebody for some data and they tell me, I think this is what it means, I'm not going to stand in front of a group of people and tell them, I think this is what it means. But I will tell them, this is where the data is leading us, And these are the questions that we're going to ask to keep improving the data that we have.
That's a fair way to put it.
There's no guarantees in anything, right? And again, it sort of goes back to the idea of risk. So how well can we understand something and recognize that sometimes it falls out of that loop,
Yeah.
right? Uh, Speaking again as a respiratory therapist, tragedies happen,
They do.
but we can limit them,
Yes.
right, as best that we can.
Can you talk about some of the clinical trials you're working on, or you don't talk about them until
Well,
it's
I should
time?
probably say two things,
Okay.
right? One, we have a number of cancer clinical trials that are going on. We have a number of cardiac clinical trials. Those cardiac clinical trials are both pharmaceutical-based and also device-based in regards to the fancy pacemakers that they make these days, right?
Okay.
On the cancer side, we have medical oncology trials. We have radiation oncology trials. In the past, we've worked with COVID. I don't know if you know it. However, we had a pretty severe dose of COVID when COVID was here. The trial that we had running, we were the largest enrollers in the United States, the largest enrollers in the world for the trial that we had going. And I tell people two things in response to that. One, it tells you a little bit about what it was like to live in COVID here on the Eastern Shore, and it tells you a lot about my team being able to carry out something that was that intense.
That's
right?
incredible.
So lots of research trials going. What you should do is that if you have an interest in that, you should talk to your care provider, so your physician, and ask them if a clinical trial is available for you. The other thing is that they're not, all of the research we do is not clinical trials. We also try and understand some things, so survey-based.
Okay.
A good example of that is if we offer a clinical trial to someone and they decide not to be part of it, then we have a survey for them to fill out so that we can understand what the driver was for that. Because we really do believe being part of it improves healthcare.
What is their fear? Why did they decide not to try and
it's not always fear. It can be the burden of being part of a clinical trial, and I recognize that also. So there is increased visits.
Okay.
There's increased communication. We'll ask questions all the time, and to be quite honest, some people just don't want to be involved in that, and I completely get it. It could be fear. Some people find it very difficult to trust a system that may not have been perfect in the past. And I get it in regards to that. But we're trying to figure out what are the best ways to communicate with people so that they can make the best informed decision that they can make about whether or not they want to be part of it.
in your experience in respiratory and just healthcare in general, how did you find your way to research? So what did that path look like for you?
So I spent a lot of years in critical care. I worked in a number of different intensive care units. And I very quickly recognized how limited medicine is. Mm-hmm. And none of us want to think that way. And if you watch TV, if you watch House, I call it the sort of Rubik's Cube generation, where we sort of believe that if you can make just the right decisions, we can solve anything.
Sure.
And I will tell you it's not true, right? As much as we want to believe it, it's not true. And I became fascinated with this idea of being able to ask questions. And so from very early in my career, I spent a lot of time asking questions until people say, I don't know. And to be honest, getting to the point where you get somebody to be the people that you believe have the most information, and if you can get to the point where they say, I don't know, that's the most fascinating place for me to be, because it's an opportunity to learn.
Right.
So being in research, the very first thing you have to understand is that you have to be a lifelong learner. You have to want to do that. Mm-hmm. Not everybody does clinical research, but it doesn't matter what kind of research that you do. You have to be willing and interested in continuing to learn for the next 30 years of your career, right? So how did I do it? From that sort of basis of being in the ICU and seeing things that I thought could be done better,
Yeah.
and asking myself the question of, do I want to be a physician or do I want to be a scientist? So I have a PhD, not an MD,
Okay.
and I very distinctly asked myself where I was going to go, and it was attractive to me to go to the PhD side, the scientist side, because I was already a clinician. And so I wanted to be able to have the background education that would lead me to a career in science and higher education. So I came back to Salisbury University. I absolutely adore universities.
Yeah.
They are places that are the source of energy for me because of what it represents. The only thing that's probably higher on my list is a library, and I tell people I've been a geek all my life, and I will continue to be a geek all my life. People have to be willing to go to school. You have to be willing to be teachable, to take on information, and be willing to ask questions. To be in a career in research, that's what you need.
Sure.
And then, the reality of it is I've had a little bit of luck and a little bit of assistance along the way. And I am in my dream job right this second. It is something that I said from the beginning of my career that what I wanted to be able to do was to support a clinical research effort. And that's what I'm doing.
Congratulations,
Yeah.
dream job.
It is a dream job. I love to go to work every day.
That is fantastic.
That doesn't mean I don't have challenges. I do, just like everybody else does, right?
Absolutely.
But I never sit out in my car and wonder, do I want to go inside? I never worry about that.
So you work with a lot of data, and it's, science-based data. How does AI play into all of this?
There's a couple of things that you have to know about AI so that you can know how it can be used.
Okay.
And we just spoke about limitation of data, and you have to keep that in mind. So AI is a very fancy game of what's next. And what I mean by that is that if you have very easily, if you have typical sentences that say, what is this, and then pause, and you wonder what that next word is going to be, okay? And you evaluate sentences from the literature 100,000 times, and you find out that 95% of the time the next word is color. What is this color? Then AI is going to say color, okay? So it's a predictive device. When you take it to medicine, what you do is, so let's think imaging for a second.
Okay.
And in this particular case, let's talk about breast cancer.
Okay.
And the idea that you see particular things on the mammography, and the question becomes, if you see something, what comes next? Meaning that, is this suspicious of a tumor, right?
Right.
So what you do is you take 100,000 images, you have the computer bring them in, and what commonly is next, and you say, okay, this image 75% of the time is typical to be breast cancer, okay? And then you have to follow up. What AI isn't is a solution for everything, meaning that it's not going to replace your physicians, it's not going to replace your care providers, but it might make them better. Right? Because the limitation is that when AI gives you an answer, you have to be expert enough to understand whether that answer is valid. And that's the question that has to be asked. The technical term for what AI does occasionally is called hallucination. And for example, a hallucination might be something that is atypical, meaning that when you say, what is this? And I said a minute ago, color, right? And it may say, what is this airplane? And you have to recognize that that's not likely the answer that you're looking for. So you have to have that specialist, that clinician that's still involved in carrying that out. It's not going to replace clinicians, not at least in my lifetime.
Right.
It is a very fancy game of what is next, what's commonly next.
Okay. The hallucination part is freaking me out.
That's the real word for it.
Okay.
So maybe I can also say, is AI used in healthcare now? Sure it is. Probably the biggest example of that is in imaging, and the idea that AI has progressed to a place where it's, breast cancer or lung cancer, otherwise it's reviewed hundreds of thousands of images so it knows what the patterns are.
Right.
And it can quickly sort of alert a physician to say, you should look into this more. You can envision that a radiologist may have, 1,000 images to look through, and 10 minutes to look through them. So what can be the expectation of the radiologist, right? How
Right.
can you do that? However, AI might say, you need to look at slides 7, 14, and 137 because we think there might be something there that you'd be more interested in. So it supports that kind of effort.
And efficiency, and it helps along the way.
Yes.
Okay.
There's a nuance to it, to understanding where you can push, how hard you can push, whether you believe you're getting something truthful back or not.
Right.
That idea of understanding whether or not you think you're getting something truthful is across research, because we always get data. We get data every day. But you have to have some understanding of whether or not that data is valid. So our efforts speak to us, just like being a reporter, right?
Yeah.
Our efforts speak to us every day, and we have to understand the validity of that data.
So you can question data.
You have to. You have to understand, all data has limitations.
Okay.
And so before you can do any kind of interpretation, you have to understand the limitations of the data. So an example of that.
Yeah. Do
right?
you have an example?
So when you do a research study, you're looking for a particular population of people to work with, okay? And that population is a limitation because while you might find out something about that population, you may not be able to take that inference. So how do you take that to the rest of the world? And you have to understand that while you know something about your population, it may not be transferable to the rest of the world. So I'm going to switch this around.
Okay.
And this is part of why we're here.
Okay.
So if the rest of the world is doing research, right, and they find out information in, Colorado Springs, that this is what works for them, right?
Okay.
We can't immediately believe that that's going to be transferable to the Delmarva Peninsula. We have to have an understanding of what the limitation of that data is. I talk about limitation of data all the time. I feel like that's my biggest part of my job, is to say, can you transfer these ideas to our population?
Because the people are different.
Because the people are different. And as you said, lifestyle's different, right?
Yeah.
So it's not just sort of our DNA, which also may play a role,
Sure.
right? But it's not just to that, right? We all live different lives. We don't live in the middle of Baltimore City. We don't live in the middle of Kansas, right?
Right.
We live on the Delmarva Peninsula. We have our own dietary, lifestyle, jobs, environmental, all of those are related. Now, you can gain some understanding, right, when you look at all of the different research studies that are going on. You can gain understanding from that. But to understand how it's going to work in your patient population, you have to have local data.
I understand that.
Yeah.
That makes sense to me. Just because you're not the same.
You're not
people,
the same. You're
in a
not the
sense.
same people. You don't drink the same water. You don't. You don't eat the same foods. We're sort of an outbirth of our own microcosm of society,
Yeah.
right? And so, like I say, the thing about asking questions, right? And being a lifelong learner, you have to have some understanding of the way in which it works in other places, so that when you bring something here, you can have an inference about how you think it might work, but then you have to pay attention. So to make sure that it's doing what you think it's doing. You can't just believe it. Right?
Believe it into reality.
You can't just believe it into reality.
So if I'm interested in becoming, part of, let's say your team, but in clinical research, and what track do you obviously, actually worked in respiratory first, and then you went that route. So what could people do?
So I do think that people need some sort of experience, but the jobs are broad. And this is what I mean by that. So do we look for research nurses? Absolutely. And they have to be nurses, and they have to have some understanding of research. We do all of our own training, and so teaching people how to do that. You don't commonly find research nurses on the Eastern Shore, just saying.
You do your own training.
We train the research side of it.
Okay.
Right? But you would have to come to us knowing how to be a nurse.
Got it.
But we're also interested in people who know how to manage data. So, for example, I'll call them data scientists, right? They don't have a clinical role, but what they have is a role in understanding how to characterize data using software. Microsoft Excel comes to mind, other sort of statistics programs come to mind. And how do you orient the data that answers in a way that you can answer the questions that are being asked? And so we could have lots of people employed in the Research Institute, but if we don't have that kind of person, then we won't get anywhere. Right? So I do want to repeat the same thing. You have to be a lifelong learner. You have to be willing to know that you don't know everything, right? And you have to be comfortable with that so that you can keep exploring to know more. And I think it's also important to know that there is no pinnacle to this. Like, the only thing that education teaches you is how much you don't know. That's exactly what education teaches you.
It's not the type of job where you tie a pretty bow on it and it's done.
No.
It's never done.
It's never done.
No.
And research breeds research. And I tell people my analogy is the person that's climbing up a mountain, and they see the top of the mountain, and they're just about there. And when they get to the top, what they realize is there's an entire valley below that they didn't even know existed. And that's what that is. If that excites you, that's the kind of person that I'm looking for.
Okay. Good to know. Dr. Joyner, thank you so much for joining me and sharing this with everyone out there who's watching.
Thanks for having me.
Thank you for joining us today. I'm Jenny Pastisak with The Local Lens. We'll see you next time.